Yeah, female reproductive. Okay. So when you're asked to describe the gross morphological features, what are some of the responses we could give? Let's try make it a lively session by giving our answers in the chat box. So what are some of the gross morphological features that can be seen? Describe the gross morphology. No responses. So I can see, for example, a whitish kind of solid mass, right? And maybe we can try give responses. What do you think this is? Maybe we can put the responses in the chat box. Yes, uterine fibroids. Great. Neat. So uterine fibroids are also what we called intramural leiomyomas. The three clinical features or symptoms which they present with are bleeding, also called pelvic discomfort, menorrhagia or menorrhagia, and infertility. So if they asked this question, they'll probably ask the clinical features or the clinical symptoms and the diagnosis and probably the gross morphological features. Nate, let's move to the next one. Describe the gross morphological features of this. Let's get some responses from the chat box. What are the gross morphological features? There's a large mass, yes. Maybe we can mention something about the color, the shape. Nate has already mentioned about the shape. It's round. How about the color? Yeah, it kind of looks dark, so maybe there's some necrosis. Awesome. And it's shiny as well. Yeah. So what will be our diagnosis? Ovarian fibroma. Yes, correct. What, Nate, can you go down? So the most likely diagnosis is fibroma. What syndrome is associated with the above? So can someone tell us what syndromes are associated with the above diagnosis? Yes, that is Mage syndrome. And so Mage syndrome is a triad of three classical manifestations. Let's try name the three classical manifestations of Mage syndrome. Pleural effusion, correct? Two more. Let's see, we're doing great. Fibroma, yes. So the last one, ascites. Awesome, guys. I think we're doing well. Next, Nate. Yeah, so that is Mage syndrome, and you have ovarian fibroma, pleural effusion, and ascites. Now we go to the male reproductive tract. So as we look at this picture, can we give some gross morphological features of the picture shown? Maybe we can describe what we can see. So like for me, I can see some areas which sort of look yellowish. Right. I can see a cavity in the middle of the organ. There's areas of healing. I don't know what you mean by healing. Maybe you can elaborate further on that. But it could be. Yeah. I can see some probably dark spots. Yeah, so like, this is some of the ways that you can describe this organ. So what are our diagnosis has already been shown to us. That is advanced prostate carcinoma. So for the advanced prostate carcinoma, which part of the prostate do you expect to find it? Anterior, posterior, near the urethra? So where do we expect mostly to find the prostate carcinoma? Any tries? The posterior region. Awesome, guys. Awesome. Neat. So posterior zone of the posterior part of the gland is where it mostly arises. Now for the description, yeah, we have the white, gray-white lesions with ill-defined margins. And also you can include this sort of a hole or a cavity in the middle of the organ. Okay. Now, so that is where the urethra passes through. So that is the prostatic part of the urethra, or the prostatic segment of the urethra. You also have the membranous and the phallic part. Next, what can we see grossly from this picture? What are some of the gross morphological features? There's a lesion. Yes, I agree. Maybe let's talk about the color. What colors can you see, especially on the sort of bottom left-hand side of the image? Yes, there's a dark area, and this dark area signifies necrosis. Awesome. Also, in that area of necrosis, I see something like a hole. So maybe you can say is some cavitation, right? Let's talk about the space. And yes, and there's hemorrhage. Yes, there's some dark areas, and also these dark areas look kind of red, right? But you have to force it a little bit. But I think there's hemorrhage as well. Let's talk about the space occupation of what is happening here. Do you see the ventricles? What is happening to the left ventricle and what is happening to the right ventricle? Yes, so there's reduced lateral ventricle, yeah? So one of them has been pushed and it's almost going to the other side. So there's a reduced lateral ventricle. Awesome. This tumor mass, is it well circumscribed or is it fading into the other tissues? Well circumscribed. Midlife shift. Awesome, yes. So it is invading the other side or the other hemisphere of the brain. I would say it's poorly circumscribed as well. Yes. So let's try give a diagnosis for this. Any guesses as to what the diagnosis could be? A glioma. Any more guesses? Glioblastoma multiforme. Glioblastoma multiforme. Yes, so all of those responses were correct. And this is a glioblastoma multiforme. So what are some of, describe the anatomical site of the features. So we can see this is on the temporal lobe of the brain. It has affected mostly the temporal lobe. Maybe you can show that. And the gross morphological features include a variegated gross appearance. So variegated meaning it's not well circumscribed. So it has like little sharp edges that are impeding into other tissue or the surrounding tissue. So it's really not like circular or well circumscribed that you can tell apart from where it's beginning to where it's ending. It's kind of eating or digging into other tissues, right? Next, pseudopalisading pleomorphic tumor and vascular proliferation and hemorrhaging. So for pseudopalisading, when you look at these cells using the microscope, you'll notice some areas of very purple staining nuclei and some areas of less or pink staining and some areas where there's no nuclei. And when you look at these nuclei or these cells, they are there's an area where there's a lot of nuclei and there's an area where you lack nuclei. And so like this sort of contrast is what you call pseudopalisading. However, if they ask gross features, maybe you should know these ones, especially the pseudopalisading pleomorphic tumors and vascular proliferation and hemorrhage and the central area of necrosis. Those are the most important ones. Yeah, I'm told this is not pseudopalisading is not microscopic. So, and sorry, it's microscopic. Yeah, so pseudopalisading is a microscopic feature, not a gross feature. So forgive me for that. Maybe I can add that as we continue. Now, we've given our diagnosis as glioblastoma multiforme. Some of the diagnostic techniques you can use are imaging, so MRI, CT, and GFAP, it's GFAP positive. I'm not exactly sure what this is, I've forgotten, but maybe in a free time you can check, or if anybody knows exactly what it is, can write it in the chat box. Next, what are some of the gross features that we can realize from this picture here? Any tries? There is definitely a mass. Is this mass well circumscribed or poorly circumscribed? And what is the color of this mass? And is this mass impeding on other tissues? Yes, so it's well circumscribed. What is its color? It's a black mass. It's a black grayish. And what's happening to the hemisphere? There's also sort of a midline shift as well, right? So it's occupying a lot of space. It's mass occupying. Now, what could be our diagnosis? It's necrotic. Yeah. What could be our diagnosis? Any tries? Okay, so maybe if I can help. So where this mass is arising from, there is sort of a fold or a sheet covering it. So neuroblastoma. Any other tries? So there's a sort of a sheet, yes? And this sheet is what you call dura. So this tumor is arising from a sheet of dura. So which tumor arises from the sheet of dura? I've seen there's some tries. Meningioma, exactly. Awesome, guys. So that is a meningioma. give two histological variants of this diagnosis. So if I look at this specimen, or if I take a piece of this specimen and look at it under a microscope, what are some of the telltale features that I can use to recognize it as a meningioma? Samoma bodies, awesome. Which other tumors present with samoma bodies? The wall pattern, yes. You have things that look like walls. Endometrial thyroid also presents with samoma, that's true. Papillary carcinoma of the thyroid, that also presents with samoma. Mesothelioma as well does. Prolactinoma as well does. There is one more we are missing. Okay. Somatostatinoma. Right. Okay, so we've mentioned the histological papillary cystadenoma. Is it papillary or serous? I think it's serous cystadenoma of the ovary. Yes, cystadenocarcinoma of the ovary. Awesome, guys, awesome. Now, the histological variants, we've already mentioned them. So we have samoma bodies, the walls, and also meningothelial cells. So that might come, and it's important to know the histological variants of the meningioma. Right? Okay, so from this picture of the brain, from this slice of the brain, what are some of the gross morphological features that we can observe? Now, there's an area of infarction. How have we known there's an area of infarction? Because of the black necrotic mass, or the black mass that we can see on the right-hand side. And also we can see small dots-like structures spread throughout the parenchyma. So it doesn't matter whether it's gray or white matter, you can see those interspersed small dots, which are dark in color. So that might signal things like lacunar strokes. Okay, so what will be our diagnosis of this? Any tries? A cerebral infarct. Any more tries? Yeah, so a cerebral infarct. It. Awesome. So that's an ischemic stroke or an acute occlusive medial carotid, cerebral artery infarct. So the reason why they said it's a medial cerebral arterial infarct is this area of the gray matter, the gray matter, is probably the caudate, the putamen, that area is usually supplied by the medial carotid artery, the lenticulostriate branches of the medial cerebral artery. And so that's why you see, if something blocks the middle cerebral artery, you find that those lenticulostriate arteries are not being able to feed the gray matter especially. And that's why you find there's a lot of necrosis, because since blood is not reaching, there is infarction first. And once infarction occurs, you get necrosis, because these areas of the brain are not being supplied by the nutrients. And is it a must you say the artery? No, it's not a must. So basic thing that you're supposed to know is the basic pathology, and that is an ischemic stroke. An ischemic stroke, because why? Blood is not reaching that area of the brain properly, probably because there's occlusion of an artery. But just saying ischemic stroke, I think should be enough. Right? State two possible mechanisms of the above. thrombotic, or embolic. As we were saying before, blood does not reach this place in the brain. That's why it lacks nutrients and it eventually dies. Then the next question we ask ourselves, why doesn't blood reach this area of the brain? What are some of the branches or vessels that blood uses to pass to this area of the brain? And then you can now start questioning. Medial cerebral artery, internal carotid, and so common carotid. What are some of the common pathologies that can occur? You can find stenosis, thrombosis, and embolism. Maybe air has entered inside the artery. Maybe there is plaques which have broken and gone and blocked the arteries. And these are very common, especially in the bifurcation of the internal and external carotid. So those are two phenomena that can cause the above named pathology. Great. Next, what are some of the things that we can see in this diagram? Something very peculiar is happening on the right side, especially. What could this be? Exactly. There's a huge cavity. Huge cavity. What could our diagnosis be? Any tries? Necrosis with a cavity. I think that's correct, right? Yeah, so this is remote medial cerebral artery infarct, which will just lead to necrosis, right? Because the area is not being supplied with blood, nutrients, and also its metabolism byproducts are not being removed. So this leads to necrosis. Now, the mechanism here is how this necrosis sort of comes about. So initially, you have an ischemic stroke, and the type of necrosis that the brain undergoes is called liquefactive necrosis. So when I take a slice of this specimen and look at it under a microscope, when this sort of necrosis is less than 12 hours, I'll observe red neurons. So red neurons sort of signify the beginning of necrosis or the cell death inside the brain. Now, what will happen next is neutrophils will invade this area to try and ward off or try and produce inflammatory responses and to try and sort of remedy what is going wrong or the pathology that is going wrong. Also, you'll have microglial cells, and microglial cells and granulation tissue infiltrate. Microglial cells are the cells are the immune cells that are found inside the brain. Like, for example, there you can say you have Kappa cells, for example, in the is it the liver and Langerhans cells in the skin. So these are the macrophages that are found in the brain. So they quickly go into the brain and try to see what is going wrong. And in this process, they'll now start forming the pus inside the brain and this liquefactive necrosis. So as they go there, they are continuing to remove all the damaged tissue. And in this process, this cavity is sort of forming. And at the end of the day, once all these inflammatory cells have entered this place and they are trying to destroy these infected or dead cells, they lead to formation of a fluid-filled cysts. And this whole process, what they leave behind, is what we know as gliosis. Next question. A 45-year-old male died in a road traffic accident. A postmortem showed acute hematoma with features of raised intracranial pressure with herniation. What is the cause of death? So the cause of death is brain injury secondary to road traffic accident. Maybe I'll explain this. What is the mechanism of death? Let's read this, then I try to explain. The mechanism of death is herniation caused by intracranial pressure due to an acute hematoma. So these things sort of happen sequentially. So this person was okay. Maybe they had an accident few minutes ago. So before a few minutes ago, this person was okay. But how did the chain of reaction or the chain of events occur? So the first thing that happened, this person had a road traffic accident. Say they were hit by a motor vehicle. Then what happened when the motor vehicle hit them? Maybe their skull caved in. So after their skull caved in, it means that the blood will start seeping inside the meninges. Then it will start occupying space. So what happens when the blood is occupying space? It is exerting, and the blood is occupying space inside the brain or inside the skull, and the skull is sort of rigid. It is exerting pressure into the contents of the brain. So these contents have to find somewhere to go. And when these contents find a hole or a space that they can pass through, maybe probably where the injury occurred, they start squeezing through this space. And once they start squeezing through this space, that is what will probably cause the person to die. So what was the cause of the person dying? The cause of the person dying was the road traffic accident. They were hit by a car. That's what kicked off the chain of events. So the cause, what I usually think of is what kicked off this chain of events for the person to die. Were they sick? So if they were sick, and maybe they got tuberculosis, that was the cause of death. That is what kicked off the chain of events for this person to head towards death. I think of death as a journey. So what kicked off the events? That was the road traffic accident, which now led to the brain injury. Now, what was the mechanism of death? Once this person got the road traffic accident, say blood started filling the meninges. And since blood is filling the meninges, it is exerting pressure. So because the skull is a solid organ and it won't budge. So where is this pressure going? It is going against the brain or against the parenchyma of the brain. So you'll have increased intracranial pressure. This increased intracranial pressure will lead to herniation of the contents of the brain. And once the contents of the brain have herniated, this is what will lead to the person dying. So you see, it's kind of a journey. And from that journey, you can pick what happened sequentially. So the cause of death was road traffic accident, and the mechanism was once you get hit, blood seeps into the skull and it increases the pressure inside the skull. The contents inside the skull try to find a place where they can run to, and that is what will lead to herniation. And once your brain content has herniated, that will probably lead to death. So that is the mechanism. The manner of death is unnatural. So things that are natural are, for us, unnatural things is something that can lead to legal issues. That is unnatural. But the natural causes of death is probably things due to sickness or things that were anticipated. Neat. Okay. I'm not sure if they can bring the MRI images, but we can just do this as well. What can you see in the pictures? There is a mass. Where is the mass? Is which part of the brain or which part of the central nervous system? The medulla, correct. Awesome. So, has it occupied the whole medulla or part of the medulla? And also, is it well circumscribed or poorly circumscribed? Okay, so well circumscribed, yeah. Now, what will be our diagnosis? Any tries? An astrocytoma. Any more tries? Okay, so maybe we can go down. So the answer is pilocytic astrocytoma. It's a very common in which age bracket? 12 to 18. 12 to 18. Okay, so maybe we can go down. So the answer is pilocytic astrocytoma. It's a very common in which age bracket? 18 to 20. 18 to 20. Okay, so maybe we can go down. So the answer is pilocytic astrocytoma. It's a very common in which age bracket? 18 to 20. 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 18 to 20 where in which age bracket is astrocytoma very frequently diagnosed? Is it the young? Yes, the children, especially 5 to 15. Awesome, guys. I think we are doing well. Maybe we can go to the next diagram. Maybe we describe the gross morphologic features of this diagram, which is still pilocytic astrocytoma. Maybe we can quickly put our responses in the chat so that we go on the right picture. I can see this. Yeah, it's sort of cystic. Awesome. So we can use words like cystic, well circumscribed. I can see also in the right picture where the pointer is, there's also a dark area. And you say dark area is synonymous to necrosis. Red areas synonymous with hemorrhage. White areas, awesome. Maybe we can move to the next. Nice. What can we see grossly in this? Maybe if we move quick, if I miss something, you can tell me. I can see on the left side there is a dark area, which is in fact, of course, can also be red, which is hemorrhage. Anything else out of the ordinary from this? Yes, swelling. And how can you tell that there's swelling? If you're given a picture, there's a reduced ventricle. Awesome, that's correct. There's also one other thing that can tell you there's swelling inside the brain. Yes, the gyri. When the gyri seem flattened and the sort of straight, you know that there's swelling. Now, what is the diagnosis for this? Hemorrhagic infarct. Maybe I agree with that. Sorry. Next. Right. So this is a cerebral infarct from arterial embolism, which often leads to hemorrhagic appearance. So I think the only one side was spot on. That is an infarct, a hemorrhagic one. Right, the characteristics, see, there's edema, we were told there's swelling, so that was right. And it was evident by maybe the crossing of the midline or the midline shift and the straight or flattened gyri. There's acutely edematous infarct tissue. They produce a mass effect, and we saw that by the midline shift. And there's decrease in size of ventricle on the left with a shift of the midline. We were also told about the ventricle. So you guys actually saw everything that will point you out to the diagnosis, which is awesome. So there's a question, how do we differentiate, I'd assume, the hemorrhagic infarct with glioblastoma multiforme? Maybe for the glioblastoma, it's sort of, though it's variegated, we said it is variegated, it is more sort of circular, or maybe in quotes, well circumscribed. But for this, you see, it's not really well circumscribed. And also for glioblastoma, it sort of has a central area of necrosis. But for this, you can't clearly see the central area of necrosis. It's like a whole segment has been necrotized, or the whole segment is dark, meaning or red, meaning there's hemorrhage. So I think that can help you, especially the central area of necrosis. Now, what can you see in this? The gross morphologic. Any trace? There's hemorrhage, awesome, evidenced by red. Embolus. How can you tell that there's an embolus? An embolus, blood clots. Awesome. So what could be our diagnosis? Hemorrhage at the brain, at the base of the brain, yeah. So what could be our diagnosis? A berry aneurysm. So let's try to think of it from this way. A berry aneurysms, where do berry aneurysms occur? In which vessels, especially? So maybe we can start from what in the circle of Willis, right? And what causes the berry aneurysms to occur? What causes? So maybe hypotension. Maybe you can get hypotension and you still don't have berry aneurysms. And someone says weak walls. Exactly. So that's true. You get weak walls. This is because there's lack of the tunica media. So since you have the lack of tunica media, the walls are weak, therefore they are predisposed to breaking or rupture when you have hypertension. Now, in which part of the circle of Willis, between which two vessels do you find about 90% of berry aneurysms? The anterior communicating artery, and the middle cerebral artery. Yeah, so the anterior part of the circle of Willis. Awesome. And in the circle of Willis is found in which layer of the brain? So, for example, you can say there is epidural, subdural, subarachnoid. In which layer of the brain do we find the circle of Willis? Subarachnoid. Awesome. So if I have a berry aneurysm that ruptures and blood spills, it will spill into the subarachnoid layer. So I think the correct pathology here is a subarachnoid hemorrhage. Awesome. And you've seen how that comes about. Neat. Sorry. Let's go down. So that's a subarachnoid hemorrhage. Yes, and it's caused by, now the berry aneurysm will come as a cause. And also atrioventricular malformations. And what is the characteristic feature of subarachnoid hemorrhage? Do you have lucid intervals in a subarachnoid hemorrhage? For example, if I got a subarachnoid hemorrhage, will I have a lucid interval where I sort of lose consciousness, I gain consciousness again, and then I lose it? No. So where do we find the lucid interval? in the epidural. Awesome, guys. Yeah. Which hemorrhage do we call also which experiences thunderclap hemorrhage or thunderclap headache? The subarachnoid. So for this, the patient will come and say they felt the worst headache of their life, a thunderclap headache. Let's move to the next one. What was the question for this? What is the diagnosis? So the diagnosis, I'm sure you've already seen it. So it's Alzheimer's. What are some of the characteristics that will guide us to say this is Alzheimer's? What can you see in the picture? And NFTs. So the tangles. These tangles are made of what? Beta amyloid deposit. That's correct. So so we should be careful not to confuse the sorry, let's call them NFTs because I'll butcher it. So the NFTs and the taus, right? So between the taus and the beta amyloid plaques and the tau proteins, which ones are found intracellularly and which ones are found extracellularly? Yes, the tau proteins are intracellular. Therefore, it means that the beta amyloids are exactly extracellular. Nate, maybe we can move down. Sorry, maybe we can just move down. Yes, the beta amyloids are extracellular. So what are the microscopic of the disease being shown? We have the neuritic beta amyloid plaques, which are extracellular, and the neurofibril NFTs, which are intracellular. Now, the neuritic plaques are formed by beta amyloid, and the NFTs are formed by the tau proteins. Now, describe the gross morphology of this, or the gross morphology that can be seen in the image. Maybe we can quickly put our responses in the chat. There's necrosis, cavitation, necrosis, evidenced by the black. There's also, yes, I see someone written hemorrhage. Yes. Which organ is this? There's also, yes, there's also a sort of a cavity in between or in the middle of the organ. Now, which organ is this? The cerebellum. Awesome. Now, there's the cerebellum, and before the cerebellum, where the hemorrhage is, that's another organ. So the cerebellum is behind, but in front, there's another organ. Which organ is this? The cerebellum is attached to it. Is communication using bundles. The pons. Great. Now, when you have hemorrhage in the pons, what do we call those hemorrhages? I think we're doing well. What do we call hemorrhages that happen in the pons? So maybe I can help. Any response? Pontine hemorrhage. I think that's a great try. Now, this is what we call diurete hemorrhages. Who can try tell us how we get the diurete hemorrhages? What could lead to formation of the diurete hemorrhages? Any tries? Now, the diurete hemorrhages come about as a result of herniation of the brainstem. Yes, someone has put it in the chat. Herniation is correct. Now, and downward displacement. So once there's downward displacement of the midbrain, and they have to fit inside the foramen magnum. So, and the foramen magnum probably is not big enough for the pons. So you get the cutting off of blood supply, and finally you end up with hemorrhages, which are called the diurete hemorrhages. Next, maybe we can move, sorry, maybe we can move them. So those are those diurete hemorrhages. Seen here in the pons are secondary to downward compression from herniation of the medial temporal lobe that leads to stretching and ischemia or perforating arterioles. Compression can result from a variety of lesions with mass effect producing herniation, hemorrhages, edema, inflammation, and neoplasms. So when you have neoplasms or space-occupying lesions, they will tend to push the brainstem downwards. And once you push brainstem downwards, the pons won't be able to fit inside the foramen magnum. And this will lead to cutting off of blood supply inside the pons, and therefore you end up with the diurete hemorrhages. Let's move downward. Now, what is the underlying pathology? Try it in the chat box. Tubercular sclerosis. I think that's correct. Let's move down. It's pretty straightforward. Three characteristics are, when probably I look at the brain, I'll find wide, flat, firm gyri, candle gutterings, and also SEGA. SEGA is an abbreviation. I've forgotten what the whole abbreviation is. Maybe someone can put it in the chat box. But the first two are the important ones. Wide flat gyri and candle gathering. SEGA is subependymal giant cell astrocytoma. Okay, awesome. Great, next. Maybe we can move down. Now, what can we see in the image displayed? There's an abscess. There's also yellow exudate at the base of the brain. There's an abscess. Now, what color is this abscess? We've said yellow, right? And from the base of the brain, from where to where is it extending? From which organs in the brain is it extending? A clue, so maybe I can just say it's extending from the, yes, cerebellum, correct. So it's extending all the way from the optic chiasma and going, yes, correct. So optic chiasma going all over the pons, on the midbrain, and it's ending at the cerebellum. Now, what could be the diagnosis? TB. Yes, so the answer is TB. Now, when you're asked to describe this gross morphology, what you say is there's a thick, yellow, web-like exudate running from the optic chiasma all the way over the midbrain and over the pons and over the cerebellum. And their diagnosis will be TB. Now, let's describe these lesions that are being pointed at. How can you describe them grossly? So, well circumscribed, that's correct. How about their number? Are they single or are they multiple? Solid. Yes, solid is true. Yes, they're multiple. I can see more than one. Now, what could be our diagnosis? A tuberculoma, correct. You guys are doing great. Let's move down. Describe the pathologic appearance. I think we already did. Our diagnosis was TB, and the arrows are pointing at a tuberculoma. Now, who can give us the diagnosis of this childhood abnormality or this embryonic abnormality? Holoprosencephaly, correct. Now, there are 3 types of holoprosencephaly. Which types are these? How can you name the types of holoprosencephaly? There's semilobar, bilobar. Yes. One more. Yeah, so there's semilobar, alobar. Now, and anencephaly. Now, in which week do we get this phenomena happening? In which week of early childhood development do we get this happening? Week 3, 4? Third week? So most of us are saying third week, around 18 to 24 days. That's 3 weeks. Yeah, maybe most of us are saying 3 weeks, maybe. So 2 to 3 weeks. I'm not 100% sure, but I think maybe it's 2 to 3 weeks as well, or 3 to 4 weeks. Now, what happens so that this can happen? What is the underlying pathology that is occurring so that you can get holoprosencephaly? Maybe we should confirm the dates. I'm not sure, really sure, but most of us are 2, 3, 4 weeks, 3, 4 weeks. Okay, so 5 to 6 weeks. Now there's failure of cleavage of the prosencephaly into 2 hemispheres. Yeah. So to be clear on the dates, answer is 5 to 6 weeks. For 2 to 3 weeks, you usually have failure of closure of the neuropause. So when you have failure of closure of the anterior and posterior neuropause, is when you'll get things like the neuropore defects, such as spina bifida, then the meningeal cell and myelomeningeal cell. Now, after that, after 5 to 6 weeks, is when you'll have the holoprosencephaly. This is where you have the prosencephalon failing to differentiate or failing to divide into 2 hemispheres. And I see most of us has gotten it correct. Now, just to be keen, or just to reiterate, when you have 2 to 3 weeks failure occurring, is when you'll have the neuropore defects. Now, answer is holoprosencephaly. Maybe we can move down. What are some of the presenting features of the abnormality? We have features such as cyclope eye, cleft palate, proboscis, and agnathia. What is the common association? So usually mothers or children born to mothers with maternal diabetes have been found to have a higher prevalence of this condition. Also, we've been told the touch infections. For the touch infections, can somebody put them down on the chart what they are? Toxoplasma, rubella, toxoplasmosis, yes. How about the O? Herpes simplex. Others. Awesome. Maybe we can move down. Now, there's a specimen of the brain here, and something is missing. What is missing from this specimen of the brain? The corpus callosum. Yes, so the corpus callosum is missing. What would we call the diagnosis, or what diagnosis will you give to a patient? Yes, callosal agenesis. What are some of the characteristic features that present when you have callosal agenesis? What are some of the features that present with callosal agenesis? We have this kind of bat-wing appearance of the brain matter. Nate, maybe we can move down. Now we have bat-wing lateral ventricles and a bundle of Probst. Now you have abnormal cingulate gyrus with radiating gyral pattern. That's the morphology. So the abnormality is callosal agenesis. The morphology, you have an abnormal cingulate gyrus, and there's a radiating gyral pattern. And then these are some of the characteristics. Important one being bat-wing lateral ventricles. Is it even compatible with life? I'm not sure. Maybe someone can tell us in the chat if it's compatible with life. Now, what is the diagnosis of shown in the picture? Yes, this is Danny-Walker syndrome. Now, what are some of the features that occur when you have Danny-Walker syndrome? So maybe you'll have this sort of agenesis of the cerebellar vermix, dilated fourth ventricle. And so someone has asked how we know, and we've been told there's agenesis of the cerebellar vermix. So when you look at the brain in the right picture, there's no vermix, there's no that like a white bundle that is usually in between the two cerebral hemispheres. and we can see it's absent. So there's a genesis of the vermis, and that's the telltale sign of Abdani-Walker syndrome. Other responses have come in, such as there's hydrocephalus, a large posterior fossa, a dilated fourth ventricle, and all those are true. I think we're doing well. Maybe we can move to the next one. Ataxia works or seizures. And we've been told also the question on ataxia works or seizures. I'm not sure what that is all about. Now, does attack? Yes, and we've been told callosal agenesis is compatible with life. Does ataxia or seizures happen? I think ataxia might happen. Seizures, I'm not sure. Because seizures usually a generation of abnormal electrical activity, either from within a focal point inside the brain or inside the parenchyma of the brain, or maybe general. I'm not sure if they occur from the cerebellum, but maybe someone can check. Now, what can we see in the picture? An egg fried appearance, which is typical of oligodendroma. Awesome. Which other pathology presents with egg shape or egg fried appearance? There's also another one which is very common. Yeah, there it is germinoma. Let's move down. So that's the oligodendroma. Now, what can you see from this image? Multiple sites of necrosis. Maybe you can say multiple cysts, multiple diffuse necrotic areas. Now, let's try come up with a diagnosis. What is a plausible diagnosis for this? Pilocytic, global cerebral ischemia. Now, these lesions, are they well circumscribed or poorly circumscribed? I'll say well. And also I'll say they are multiple. Now, yes. Now, why did we say pilocytic? Where is pilocytic mostly found? The cerebellum, but this is the brain parenchyma. So maybe that's not the most appropriate one. Maybe we can try, but I'm not completely ruling it out. Now, metastatic melanoma. Yes. So how did we come with metastatic melanoma? So I think yeah, that's correct. We go with metastatic melanoma. So they are multiple and they're dark areas. Yes, the multiple masses, metastatic melanoma. There are multiple masses, right? And they don't have a primary focus or the primary area of the tumor where it arises, and they are well demarcated, but they are malignant. So maybe it's not glioblastoma as well, because For that, maybe you would have seen a central area of necrosis, right? And some hemorrhaging, which is not really seen here. Also, it's not maybe pilocytic because that's mostly found in cerebellum. But those were great tries. Maybe we move to the next. Now, what can you see in any of these images? Any tries? There is necrosis evidenced by the dark areas. There is butterfly appearance of the necrosis. Yes, as well evidenced by the black areas. Maybe someone mentioned something about the micrograph, the stained image on the bottom left. There is pseudopalisading, correct? So you can see there's an area where you have sort of many nuclei, which are very purple and black. And then next to it, you have this kind of pale area where there's like less nuclei, right? And then on the other side, it's like a border, it's like a road in between two mountains. On both sides of the mountains, you have a lot of pleomorphic cells or nuclei, right? Very dark colored nuclei on both sides of the road. But in the middle of the road there is like almost no nuclei. So that's what you call pseudopalisading. Maybe we can move to the next. Oh, sorry, I forgot to ask the diagnosis. The diagnosis is from glioblastoma multiforme. Also, the ventricles, maybe they are smaller, and that means that the lesion is space occupying. Now, the morphological appearance is necrotic, hemorrhagic, and infiltrating. Necrotic evidenced by the black areas, hemorrhagic evidenced by reddish areas, and infiltrating evidenced by the midline shift. The features expected to see on microscopy, there is a foci of necrosis, pseudopalisading by malignant cells. We saw the pleomorphic nuclei, and also there is endothelial cell proliferation. Let's move to the next. Now, okay, so there's this cell that we can see, sort of circular. And what do we call this kind of circular appearing image? This is a wall, correct? When we said, where do we find these walls? Onion appearance. Yes, so there's sort of onion features that appear like onion-like, and we've called them walls. So in which pathology do we find them? Yes, meningioma. I think we are doing well. Let's move to the next. Onion, peel, arrangement, walls, meningioma. Yes. Now, we have another picture showing pathology. Now, where is the pathology in this picture? In which organ? Any tries? In the cerebellum. So what in the cerebellum is indicative of pathology? Maybe you can describe using the color, the borders or the margins. Maybe there are holes, cavities. So it's whitish. Also gyri. Gyri may be the cerebrum. Yeah, but we're looking at the cerebellum. It is a whitish solid mass, exactly. So there's there's a whitish solid mass. Now, what could this mass be? Medulloblastoma. Anyone tries? Great. Let's go down. Answer is a medulloblastoma. So for the pilocytic astrocytoma, we said it's more of cystic. It's more of like fluidish or serous fluidish inside it. But for this, it's solid tumor, and it's whitish. For the pilocytic, there was also like some areas of necrosis, black necrosis, and it was very cystic. Now, someone give us the diagnosis. This is spina bifida. Also, what was on the histology that would indicate medulloblastoma? Now, for the image above, maybe we can go back up just for a little bit. Let's go up. Someone has asked, what could help us know that the image of the medulloblastoma and the histology was a medulloblastoma? Any ideas? So we've been told there's a blue cell on which is called the rosette formations. Awesome. So you could tell by the rosette formations. Right. Now we've said this is spina bifida. Yeah, so this is spina bifida. What was the cause of this abnormality? There's a failure of fusion of the posterior neuropore. That is in 3 to 4 weeks. Yeah, so I think maybe we just go with spina bifida of the meningeal cell. The meningeal cell, I don't know. Can we see the spinal cord from here to call it meningeal cell? Yeah, so since you cannot see the membrane or spinal cord, we just call it spina bifida. Let's move down. So what's abnormal about this organ? Does this organ usually look like this? What could be going wrong with this organ? There's a breaking of the quadrigeminal plate. Maybe you care to explain what exactly that means? And also, as you explain that, maybe tell us what kinking is as well. Apart from the breakage of the quadrigeminal plate and the kinking, what else can we observe? Yes, maybe I think the easier ones are things like the downward displacement. And someone has asked what the organ is. Herniation, I think, is easier. Yeah, so there's herniation and there's downward displacement of this organ, which is the cerebellum attached to the stalk of the medulla or the midbrain in the pons. Now, What is the diagnosis that we would give to such a patient? Arnold Chiari. Which type? Someone says 2, someone just says Arnold Chiari. Which type of Arnold Chiari is this? Type 2. How did we come up with a diagnosis of Arnold Chiari type 2? Mhm. I'm being told that Arnold Chiari is the other name for type 2 Chiari malformation. So what I meant, maybe we can differentiate between type 1 and type 2. So type 2, yes, I've seen the chart there is. Yes. So for type 1, you only have herniation of the midbrain, right? Not the medulla. So in type 1, you'll only notice there's herniation of the medulla. But in type 2, there's herniation of both the medulla and the cerebellum. And that's why this is type 2, because also part of the cerebellum has herniated outside or below. If it was type 1, the cerebellum will have remained intact and only the medulla would have herniated downwards. Let's move downwards. Yeah, so this is kind of a pictorial showing that. Now, so for type 1, there's caudal displacement of the cerebellar tonsils. For type 2, let's move down. There's displacement of the cerebellum, brainstem, and fourth ventricle. And for type 4, there's cerebellar herniation, and there's also occipital lobe herniation, in addition to the brainstem herniation. Now, because there was cerebellar tonsil herniation and also there was brainstem herniation, that's why it was type 2. The characteristics include small posterior fossa, extension of the medulla below the foramen magnum. Yeah. Let's move down. There's also kinking of the medulla, breaking of the quadrigeminal plate, hydrocephalus, and meningocele. So, but the more easier ones to remember are probably the herniation and the downward displacement. Describe the pathology scene. Now, can someone put in the chat the description of this pathology? Yes, vesicles along a dermatomal distribution. What would be the diagnosis? Herpes simplex 1, shingles. So their diagnosis would be shingles. Awesome. Next, shingles, herpes zoster. So there's multiple vesicles with a dermatomal distribution. Shingles. Careful not to write psoriasis. We move to bone, and I think this is probably the last section. Now, how do you describe the pathology of this bone? Grossly. There's hemorrhage, yes, evidenced by black area. Maybe we can move to the picture below because that is more apparent. It's a mass. Oh, so it's only that. There's a big mass, and there's hemorrhage. What else? From this other picture here. There's some cystic degeneration. How about the color? Yes, there's sort of yellowish. And there's hyperemia. I agree. I agree there's hyperemia. Now, hyperemia, hemorrhage, it can be evidenced by the red, sort of red tinge. Now, what will be the diagnosis? Osteosarcoma, correct. Let's move down. The osteosarcoma. Now, the gross features of the osteosarcoma include it's a bulk tumor with various levels of necrosis and hemorrhage. And also you have lifting of the periosteum. That's the gross features. Also, something else that came is what are the microscopic features of osteogenic sarcoma? Also, I've seen there's some questions on the chat. How do you differentiate from TB of the spine and Codman triangle? I think that was answering how you differentiate it from TB of the spine. Now, someone tell us the microscopic features of osteosarcoma, which is important. Sundry appearance, that is a radiological feature, and maybe you can use it to differentiate it from the TB one, also the Codman's triangle. Now, what are the microscopic features of osteosarcoma? Maybe someone can put them on the chat. I think these are important. Yeah, pleomorphic cells. Okay. So, yeah, pleomorphic cells. I think I'm not very sure, so maybe we can confirm this. And I think it's important to know the microscopic features of osteosarcoma. So we've been told there are pleomorphic cells. There's hyperchromasia or hyperchromatic nuclei. There's malignant osteoblasts. And I think some of these apply to microscopic features of many neoplasias. So things like the pleomorphic cells and the hyperchromasias. Maybe if they're in a tight fix and they've asked microscopic features of a certain type of neoplasia or malignancy, maybe think about writing those. Sorry. As we add this, maybe we can describe the radiological features. That's the sunburst and the Codman's triangle. Pleomorphic cells and malignant osteoblasts. Maybe hyperchromasia as well. Let's move down. Name two presenting clinical features. We have the pathological fractures, bone pain, and swelling. Now, there's some specimens here. Maybe we can try describe them. First, maybe we can start. What organ do we think this is? The thyroid. Yes. How did you come up with thyroid? Sorry. Butterfly bilobed. Awesome. You guys are doing well. So what could be the diagnosis? thyroid carcinoma. Yeah. Papillary thyroid carcinoma. Yeah. Maybe we move down. That's a clearer image. Now the organ is thyroid. So the first image is papillary thyroid carcinoma. The second image is follicular adenoma. But of note, it is difficult to differentiate between follicular adenoma and thyroid carcinoma. So maybe if you find it in the exam and you don't want to commit too much, you can write thyroid neoplasia. And or maybe if you know the diagram well, maybe you can now specify papillary thyroid carcinoma. These two presenting features, is dysphagia, right? Because it has increased in size. Now it's blocking the esophagus because it's impinging or pinching down on the structures of the neck. Also host laryngeal because it's probably pinching the recurrent laryngeal nerve, which supplies innervation to the muscles for voice box. Next. I think we're done with the sports that I had for today. And I think we are doing well. We've covered a lot of work on sport so far. And we started by describing terms that can help get us out of quick fixes, the sizes, the cystic terms, the colors, and all that. So maybe the PDF will be sent to you and you can be able to revise. Now, I wanted us to do some sport quickly or some MCQs, but maybe we can just finish up on sport. I have another paper. Now, we did this the other time. We'll do the ones that we didn't. So maybe should we repeat or we look for the ones that we didn't do? Maybe we can vote on the chat. Because this other PDF has things that we have done before. Okay, so we should repeat so that maybe we can reinforce the knowledge that we had or we have now. Okay, so from the top. Good. Now, maybe this will move quicker because we already did. Describe the gross morphology. What can you see in this image? Let's talk about those intestines. How do they look? Maybe color-wise? Ischemic, yes, because they're black. Now, we said which blood vessel supplies this part of the intestines? Yes, superior mesenteric artery. Now, what would cause the jejunum to become necrotic or ischemic? Occlusion, exactly, occlusion of the superior mesenteric artery. So this is jejunal ischemia leading to necrosis, and the cause could be occlusion of superior mesenteric arteries, and the occlusion could be maybe via thrombus or emboli. Great. Next. Sorry. We've seen this before. Maybe someone can tell us what the diagnosis is. And also, okay, let's just start by diagnosis. Leiomyoma or uterine fibroids. Awesome. Are these growths malignant? Do we expect them to be malignant? No, they are not malignant. What are some of the risk factors of leiomyoma? Hormonal therapy, multiple what? Estrogen exposure. Obesity, alimenaki. Okay. So. Now we said sorry. What are some of the features that leiomyomata present with? Bleeding, which we called menorrhagia. Uterine bleeding. Was there pain? Yes, pain. Infertility was there. Irregular menses. I think you guys are doing excellent. Let's move to the next one. I think this is the same thing. The uterine leiomyomata. We have the heavy and prolonged bleeding, menorrhagia, urinary frequency because it's a mass, and since it's a mass, it's pushing on the bladder, therefore reducing its effective volume. There's also pelvic pain and abdominal pain. I think we can move on. Yes, the one on the tray is still a uterine leiomyomata. Someone has told us to try differentiate it between the huge uterine leiomyomas and the fibroids. Yes, I agree. It looks exactly like the fibroma. But I think maybe the difference comes in when you cut them and look at what is inside. Maybe we can go up and try and differentiate the two again. The bottom one, the other picture, the one with multiple pictures. Now, maybe someone can help us differentiate between this and the fibroid we saw earlier. No, not the fibroma we saw earlier. The fibroma kind of had, when we were talking about the fibroma, we said something like dark, necrotic. Maybe that's something maybe which can help. Someone has said the leiomyoma has walled appearance when cut. And the fibroma is kind of white or yellowish inside when it's cut as well. Let's move down. Yes, also the fibroma looked like one big mass. This looked like two masses. Now, what can we see in this image? Let's describe the pathology or the gross morphological features. Knife-edge gyri, knife-like gyri, which is characteristic to what pathology? Narrow gyri, wide and sulci, atrophic gyri. Now, in which lobes of Alzheimer's? Okay. Now, in which lobe do we find is this pathology dominant in from this picture? Temporal, right? Is the frontal lobe affected? Oh, yes. So we can see that the whole brain has been affected with this pathology. And so the correct answer will be Alzheimer's. Let's move down. Now, what will have happened? Yes, knife edge. Now, sorry, is maybe someone describe also what can be seen in this picture before we are shown the answer. Widened ventricles. Yeah, so mostly widened ventricles, necrosis. Necrosis, maybe where? Let me see the necrosis. Maybe someone talk about the temporal lobe, especially where we usually have the hippocampus. Exactly. There is some hippocampal atrophy. Let's move down and see the diagnosis. So the diagnosis of these two pictures is Alzheimer's. Now, Alzheimer's is characterized by the widespread or the widening of the narrowing of the gyri and widening of the sulci. And for this, it will be on all the lobes. I'm specifying all the lobes because we also have something that we call frontal temporal. It's called frontal temporal. Getting pathology. Is it frontal temporal dementia? Yes, frontal temporal dementia. Now, frontal temporal dementia, you'll only have this atrophy in the frontal and temporal lobes. The occipital and parietal lobes, when you look at them, they'll be almost intact. And for that, we also have this knife edge kind of appearance. Now, also for Alzheimer's, you'll notice that you have mesial temporal lobe atrophy. That is amygdala, hippocampus, and entorhinal cortex have also atrophied. So those are the two things or the two features that will enable you to differentiate between Alzheimer's and frontotemporal degeneration. For frontotemporal, the degeneration has only occurred in the frontal and temporal lobes, as is in the name. And also, when you look at the mesial temporal lobe, you'll notice that the amygdala, hippocampus, and entorhinal cortex, have atrophied in Alzheimer's. Also, remember we looked at the microscopic features of Alzheimer's. What did we notice from the microscopic features? Who can name the microscopic features and just put it on the chart? Yes, we have the NFTs and the neuritic plaques. And we also mentioned which ones are inside the intracellular and which ones are extracellular. Yes, so the NFTs are made of tau and they are intracellular, and the neuritic plaques are made of beta amyloid and they are extracellular. Awesome. You guys are doing extra well. Next. Now, can anybody tell us which stain is used to stain so that we can see the taus and the NFTs and the beta amyloids? Does anybody know which stain is used? The one that makes the slide look yellowish. So there's silver stain, BL, the name was starting with BI, and I'll butcher it, so I won't even say it. Maybe Bielszowski. Okay, correct. So the Bielszowski stain is used to stain these slides so that you are able to see the neuritic plaques. Awesome. You guys are doing well. I think you're doing well. Yes, and someone has told us that the Bielszowski stain is the exact silver stain that is used. So maybe there are many silver stains, and like the one used to stain beta amyloid is the Bielszowski one. Give 4 genetic abnormalities that may predispose one to this pathology. Any tries in the chat? Any genetic abnormality? ApoE? That's a good one. Let's move down. Penicillin 1. That's true. And 2. Yes. So Down syndrome, trisomy 21. Then there's also penicillin 1, 2, ApoE, and amyloid precursor protein. For the amyloid precursor protein, so basically, when you have these beta amyloid plaques forming, usually they form, how they come to form is you have the cell membrane. Let's try to picture a cell membrane. And inside this cell membrane, you have amyloid precursor protein. Let's imagine it as maybe a string that runs through the cell membrane. Now, what happens usually, we have two proteins. I think they're called alpha and gamma secretaries or secretin. Now, what they do is that they cut this protein. You know, the amyloid precursor protein is basically a protein like any other protein. So it is used up, and when it's used up, it becomes old and it has to be replaced with new protein. So usually we have alpha secretin cutting outside the membrane and gamma secretin cutting inside the membrane. When you have alpha and gamma secretin cutting this string that is running throughout the membrane, you form a soluble complex that will dissolve and go away. But usually what happens when you have Alzheimer's, the alpha secretin, which is supposed to cut outside the protein, is exchanged with what we call the beta one. Now the beta secretin, when they work together with gamma secretin, when they cut this protein, they form an insoluble compound. These insoluble compounds will aggregate, and when they aggregate, usually they sort of like form these neuritic plaques. And these neuritic plaques, sometimes you find them inside the interneurons. And when you find them inside the interneurons, they will not be enough, or they'll not be good transmission of signals. And that's what leads to sort of the pathological symptoms that you see in people with Alzheimer's. I think that was just a good, by the way. So that is the amyloid precursor protein. I was saying that so that maybe we remember the amyloid precursor protein. What is the diagnosis? Glioblastoma multiforme. Awesome, guys. You guys are doing extremely well. Now, the gross features we saw, we have the variegated gross appearance, the central area of necrosis, the pseudopalisading pleomorphic tumors, right, which we saw was microscopic, and then we have vascular proliferation and hemorrhaging. There's also some infiltration. That's why we say it's variegated. The diagnosis, we saw the imaging and the glioblastoma FAP. Forgotten again what it is. Now, this we said was the diagnosis. Holoprosencephaly occurs is which weeks of development? 5 to 6, exactly. And you said it's failure of what to turn to what? What is the underlying pathogenesis? Yeah, failure of the prosencephaly to divide into the respective hemispheres. And what are some of the features that it presents with? Agnathia, cyclopia, yes, correct. Proboscis, all that. Now, and then you said there are 3 types: aloba, sebiloba, and there was one more. So aloba is when you have one huge single lobe, like the one shown above here. Let's move on. Also, we said which mothers are susceptible or prone to getting babies with holoprosencephaly? Diabetic mothers, correct. Guys, I think we are doing well. Let's go down. So this is still holoprosencephaly. Now, that is semilobar, the semilobar type. And there's also a lobar and lobar. Move down. Now, this is what we were comparing the fibroids to. We said this is the diagnosis of this will be the fibroma. Maybe you just take a mental picture of this so that you can compare them with the fibroma. Not the fibroma, the fibroids. And maybe if someone has a definitive feature that they can help us, or that can help us to identify that, to compare the two and differentiate them, maybe they can put it in the chat. Next. I think we've discussed, so this is the fibroma when it's cut. Someone told us that one of them is cystic. Let's move down. Now, this is the syndrome associated with fibroma, Meg syndrome. And the triad was ovarian fibroma, ascites, and pleural effusion. Classify the above tumor. So this is a sex-cord stromal tumor. Yeah. Let's move down. Now, what can you see in this picture? Maybe as we wind up. Yes, there are multiple cysts. Multiple cysts, correct. Anything else? Ruptured cyst, multiple lobes. Yes, there's also multiple lobes. Great. Maybe I can move down and see the questions. How about this? Papillary bodies. What can we see? What can you describe morphologically from this? There's some necrosis. Someone says there's whitish areas. Another person says red. So the black necrosis, the red hemorrhage, yellow. There's also yellowish areas. Correct. There's cystic area. Cavity. See, someone says cavity. Clump together small cysts. Yes, all these are ways of describing this gross morphology. Now, what are the questions? 23-year-old with an ovarian mass. Give two gross morphological features. So we've said multiple cysts present. Let's move down. Enlarged ovary and grape-like vesicles, yeah, and multiloculated. So someone said multiple compartments, was it? Yeah, so you guys are correct and your descriptions are very on point. Identify the pathology of serous cystadenoma. Awesome, guys. Next, describe its histology. We have papillary projections, samoma bodies, cyst lined with serous epithelial cells. Classify the above tumor. It's an epithelial tumor. Someone asks why. Someone asks why not mucinous? Why did you go for serous and not mucinous? Grape-like vesicle, this for hydatid mole. Yes. It's also hydatid mole. Yes, grape-like vesicles, hydatid mole. You'll see that on imaging, ultrasound and all that. So does anybody have an idea of why this is serous and not mucinous? We have I'll just put them in the chat. Oh, I see it's already time. Time was caught up. Maybe the moderator should tell us if we can end here, because I know maybe other people have other things to do. Moderator.